Hello, everyone, and welcome to the podcast about COVID-19 An Update. I am Dorina Esendagli, and I work as an adult pulmonologist at Başkent University in Ankara, Turkey. I'm a part of the editorial board of the Monograph as the early career member representative. I'm very glad to welcome today one of the guest editors of the Monograph, Professor James Chalmers. He is an asthma and lung UK chair of respiratory research at the University of Dundee and a consultant respiratory physician at Nine Wells Hospital in Dundee, UK. His research and clinical interests lie in difficult respiratory infections, particularly bronchiectasis and pneumonia, including COVID-19. James is the chief editor of ERS, and he has published more than 400 peer-reviewed articles in the area of respiratory infections. During COVID-19 pandemic, James was chair of the ERS task force for COVID-19, which produced the ERS living guidelines for the management of hospitalized patients with the virus. Welcome, James.
Thank you, Dorina. Really nice to be here.
Well, we really needed a second monograph about COVID-19 because the first one was published during the pandemic and a lot of questions were still left unanswered. And we know that SARS-CoV-2 virus is characterized by a remarkable plasticity, which makes it evolve so quickly with a high rate of mutations. And this virus still continues to infect people globally. So my first question, what are the current diagnostic tools and do they still accurately diagnose the new variants?
Yeah, so the virus has absolutely been evolving. The Omicron variant has been dominant now, but increasingly we hear that sublineages have emerged. Most recently, for example, JN1 very rapidly became dominant across the world. That's a sublineage of the Omicron variant. And so we've gotten used to the fact that some of our approaches and vaccines, for example, need to adapt in the face of the virus. Fortunately, our diagnostics currently still detect the virus accurately. So PCR-based diagnostics are able to detect the Omicron variant, and many of us will still use lateral flow tests in certain circumstances, and they're still accurate in identifying these pathogens. But some of our diagnostic approaches have certainly changed. For example, surveillance, which was heavily done during the early part of the pandemic, is much less frequently done in many countries now. And so the true burden of the virus is less well known because people are testing less frequently and the population surveillance is less frequent than it was. And so as the pandemic or the endemic, as we now would sort of think about it, waxes and wanes, we may still need to adapt our diagnostic and our surveillance approaches to know exactly what's going on with the COVID-19 epidemiology as time goes by.
Yes, because if we test, we know if the disease is present. So we need these diagnostic tools for sure. Another challenging fact for the COVID-19 disease was that it was affecting a lot of organs. It was a multi-systemic disease, but lungs have always remained as the primary target. But the clinical spectrum was quite variable, changing from the asymptomatic patients to the severe, life-threatening cases. So what is the main reason for this diversity in the clinical presentation? Is it related to the variant that is causing the disease, or is it mainly patient-related? What do you think?
Yeah, I think the main reason, or the main two reasons, are the virus itself, which is able to infect a remarkable number of human tissues. So it has a preference for the respiratory tract, but we know that the SARS-CoV-2 virus can also infect tissues throughout the body. And so that explains some of the manifestations of the disease that we see that are non-pulmonary. And so that's part of the explanation. The other is the really profound inflammatory response that the SARS-CoV-2 virus initiates in patients, and particularly initiated in the unvaccinated population that we saw between 2020 and 2021 in particular. That profound inflammatory response that caused, systemic inflammatory response syndrome, viral sepsis, multi-organ dysfunction, meant that even if the SARS-CoV-2 virus itself was not causing direct damage, the secondary host response was causing profound damage to multiple organ systems. And you saw that very clearly in the early part of the pandemic, where you would meet patients 10 or 14 days post-infection. The virus was no longer detectable, but the patient had a profound ongoing self-sustaining inflammatory response that ultimately led to substantial morbidity and mortality. So I think those are the two reasons why it was such a complex disease. But the other thing I would say is I think we've under-recognized the impact that respiratory infections generally have on non-pulmonary tissues. Community-acquired pneumonia, pneumococcal disease, influenza also have a profound systemic effect. And it just so happens that with COVID, this is the first time that we've studied a respiratory viral infection in such detail to uncover all of the different manifestations. And you see that with the evolving literature now that we're recognizing also long-term effects of things like influenza that have really been neglected pre-pandemic.
Yes, and actually we do have some chapters in the monograph that are related to the specific patient populations where you explain in detail for the comorbidities that these patients have. So I recommend the listeners to have a look to those chapters as well. And we have had actually so many studies performed, including the randomized controlled trials that have addressed the treatment choices. And actually, we were following those studies and sometimes even trying some drugs that were used for different diseases as well, which later on were proved to be not effective for COVID-19 and even harmful. So we have chapter 7 of the monograph that you are also a co-author as well. And it is quite comprehensive and up to date and discusses the treatment choices in detail. So could you summarize us the main points that we should keep in mind for the treatment and what are the clues for the treatment to be successful?
I think that the pandemic was a triumph of science in many ways, but there were also some parts that could have been better done. To use that sort of Charles Dickens quote, it was the best of times, it was the worst of times. In terms of clinical trials, we've never developed effective therapeutics more rapidly for any other disease that I can think of. Very early in the pandemic, anti-inflammatory treatments, in particular dexamethasone, then tocilizumab and baricitinib were proven to be highly effective to reduce mortality in hospitalized patients. And they remain part of what is used for patients that are hospitalized and requiring oxygen or ventilatory support in patients with COVID-19. And the reason we were able to do that is the development in record time of large platform studies that were pragmatic and could enroll very large numbers of patients. As you've alluded to, there were also a lot of small studies, many of them poor quality, that gave initial hints at efficacy for other treatments or a theoretical basis for efficacy of other treatments, most famously things like hydroxychloroquine and ivermectin, that when large studies were done were shown to be ineffective. And even a meta-analysis suggests hydroxychloroquine probably increases the risk of mortality in people with COVID-19. There were certainly triumphs, but there were also some disasters during the pandemic because millions of people received off-label, unproven treatments, certainly in the early part of the pandemic. And some of those may have been harmful, and hydroxychloroquine is an example of that. So I think we're now in a position where the management of COVID-19 is much more evidence-based. The best way to treat it is to prevent it, which is with vaccination. For hospitalized patients, there's very good evidence for a number of treatments, predominantly anti-inflammatory treatments, but also some antivirals for preventing mortality in hospitalized patients. And so the evidence base is now in a mature position, and there's guidelines from the World Health Organization. And during the early part of the pandemic, there were also guidelines from the ERS that covered management. So we now have very good quality evidence for most of the things that we're doing with COVID patients.
Yes, thank you. And as you mentioned, the vaccines were actually the ones that changed the course of the pandemic, and they especially helped to reduce mortality. But we know that the number of vaccines, of doses that were applied, the types of vaccines that were applied in different geographical areas are also very diverse. But what do you think now that we have new variants? Do we need new vaccines like the flu ones that will include the most recent variants, or we can use still the vaccines that we already had, but to have new boosters? What do you think would be the approach in the future?
Yeah, great question. As we mentioned at the beginning of this, the virus is evolving over time. The emergence of these new variants and the new sublineages is mostly a response to the fact that there is immunity in the population. The virus wants to survive, and so it adapts to evade vaccine-mediated immunity so it can more effectively infect us as the host. And so as time goes on, there is going to be the need for adapted vaccines that are adapted to the emergence of these new variants. The World Health Organization, for example, has come out with statements saying that it's important that we vaccinate going forward with variant-adapted vaccines because of the increasing risk that the vaccines become less effective as the virus evolves. And so the position is that there's now very high population immunity through vaccination and prior infection as the virus evolves in line with the evolution of the virus on an annual basis or on a less frequent basis, depending on how the epidemiology evolves. High-risk patients will need to receive vaccines that are adapted to the new variants that have emerged. And you'll know that there are variant-adapted vaccines that are currently being used in Europe and other places to protect patients this winter.
Yes, and I hope that many people will have access to these vaccines, because this is also another issue. Now, as clinicians, we are dealing more with the post-COVID and the long COVID cases. And this is also another topic that was discussed in detail in the monograph, which is new and is in addition to the topics that were discussed previously. So do we have a certain definition of long COVID, and which is the current approach in the treatment basis? So what can we do to these patients? How can we follow them up?
This is a new chapter because it's a really important issue. Very large numbers of people, unfortunately, are suffering with long-term effects of COVID-19. It's a complex, heterogeneous condition. It does have definitions. The World Health Organization defines post-COVID-19 condition, which is the term used for long COVID, as ongoing symptoms beyond 12 weeks after infection. NICE in the UK has a similar definition. It has a definition of ongoing symptomatic COVID between 4 weeks and 12 weeks. And then this calls post-COVID syndrome or post-COVID condition after 12 weeks. And in the US, the CDC definition is the development of new or recurrent symptoms and conditions after the symptoms of the initial acute COVID illness have been resolved without a specific time period on that. So I think we have consensus definitions, but studying the condition is still a little bit of a struggle. It's very heterogeneous in terms of both the type of symptoms, the severity of the symptoms, the duration that they last, and the mechanisms are not fully known. And that leads on to the second part of your question, which is the treatment. That's very, very difficult because we don't know what causes the symptoms, and they're very different between different individuals. So the approach that I take, and we discussed this a little bit in the monograph, is sort of borrowed from airways disease, this idea of the treatable traits concept, which is you evaluate patients on an individual basis, identify what their primary problems are, and aim to address each of those problems. So a patient who's got breathlessness and cognitive dysfunction will have a very different treatment approach to somebody who has ongoing cough and cardiovascular complications or new onset diabetes, for example. And so there isn't, and it's unlikely there ever will be, a single approach to long COVID. It's very much about personalized medicine and addressing the individual patient's needs.
So talking about research, I wanted to ask you, how was the research in respiratory medicine affected by the pandemic? As the chief editor of ERJ, I'm sure you had a lot of articles and you did really a great job. It was hard, I think.
Yeah, I mean, of all the things that were difficult during the pandemic, working in a scientific journal was not one of them. There was so much going on at that time, but the pandemic has had a lasting impact on scientific publishing, on science in general. On the publishing side of things, we've seen an explosion in open access because all COVID-19 articles were made open access through a mandate from the Wellcome Trust. And that, I think, has accelerated the move towards open access in other fields as well. We've seen an increase in research into respiratory infections, learning from the pandemic, translating things into things like flu and community-acquired pneumonia. Big trials like Recovery have pivoted now from COVID into other respiratory infections, which has got to be good for us as respiratory physicians to see more research into these areas. But I think the biggest lasting impact of the pandemic is going to be around research methodology, because there was a move before the pandemic towards more pragmatism in how we design studies, platform trials, efficient designs. But the pandemic really showed the benefit of that in terms of delivering something that could save lives. And what I'm seeing now is, to give you an example, within ILD, there's a paper just out in Thorax on REMAP ILD, taking REMAP CAP, which was the COVID study, taking that methodology and now applying it to interstitial lung disease as a pragmatic way of testing multiple interventions in a chronic respiratory disease. So I think we'll be looking back at the pandemic for many years, referencing it as, this showed the value of a different approach to clinical research. And I think a lot of clinicians and scientists will be applying those principles to future trials and to embedding translational research into clinical trials, for example. And that's only got to be good for all of us, that we can pull something positive out of what was a really, really difficult and devastating time for a lot of us.
The pandemic has also some advantages, I think, as well. So sometimes, we have to take out some lessons. So which are the lessons that COVID has taught us so far? And do you foresee another monograph after some years, a third one?
Yeah, I mean, to take the second part of that question, COVID-19 is not going away. This remains a significant burden. We were so focused on it for many, many years during the intense part of the pandemic. We kind of want to not think about it at the moment. But if you look at the epi data, there's still more hospitalizations and more deaths from COVID than there is from influenza, for example. So it's not gone away. And actually, it's still a major disease burden. This is not something that we're going to be able to forget about or even push into the background. It's at the forefront still of what we do from the point of view of respiratory infection. So from that point of view, yes, I'm sure there will be a future monograph, but it will be very different because the pandemic is done. Population immunity is such that the challenges of COVID-19 in the future are going to be different. It's now an endemic virus, much more like the other respiratory viruses that we're used to. Maybe the lasting impact of the pandemic will be to say, respiratory infection is really important. It can bring the world to a standstill. It can shut down everything that we do in our daily lives. And so I would hope that the lasting impact of this will be, we don't ever want this to happen again. And so there'll be a sustained investment into respiratory infection research, into pandemic preparedness, so that the next time a novel virus emerges or a novel pathogen emerges, measures can be taken to avoid the kind of disruption, the kind of death, and the kind of morbidity that we saw during 2020 to 2023, because we really don't ever want that to happen again.
Thank you very much, James, for the valuable information that you gave. And I'm really looking forward. I don't know if I will be the interviewer, but I'm looking forward to read the third monograph about COVID-19. Thank you to all the listeners for being with us. I recommend them to read all the chapters of the monograph. And you can listen to the podcast of all the monographs that have been published until now at the Respiratory channel. Goodbye.